are going through a very significant time right now in terms of a massive transformation in the healthcare system. And this morning I spent my whole morning reviewing a 200-page, what could be hundreds of millions of dollars document that is going to go out in the next few weeks. So we are in a transformation. Sorry, Teresa, go ahead.
Any co-op opportunities in that document?
I would argue yes. I mean, there's massive amount of spending going on. And so when there's spending, then there's opportunities not only for co-op, but for full-time work. This transformation is not going to be done overnight. It's going to take many, many years. In fact, it's going to take longer than the next election cycle, which is in 3 years, 3.5 years. So,
Sorry to interrupt.
yeah, no, please. And anybody have any questions, or if I'm going too fast or you don't understand anything, just please ask me, and I'm happy to expand on things. But you know, it's all about healthcare. Is about teams working together, not only in delivering care, but in providing system change. So we have technology providers. We've got technology providers in the vendor forum. We've got healthcare providers, and we've got and then we've got the funder side and the policymakers. So OMD sits in a very unique spot. So today I'm going to talk to you about what's happening in primary care in Ontario. Primary care is your frontline doctors. So that's general practitioners, family physicians, specialists that are in the community. Though nurse practitioners, team-based care, they're all the primary care providers. The first point of contact, which is called primary care. Secondary care is when you go and you're referred to a specialist or to a hospital. And then tertiary care is when you're referred to a more advanced or specific care level. So that would be like sick kids, or that would be like a neurological institute, or that would be like a teaching hospital. And then there's quaternary care, which means it's the most specific and most advanced care that you can get. And that would be, an example of that would be CAMH, the Center for Addiction and Mental Health. So I'm going to talk a little bit about the health system structure and the goals of the system. I'm going to talk a little bit about the data priorities in Ontario. I'm going to talk about virtual care. I'm going to talk about AI, and I'm going to talk about what's coming down the pipe, kind of this transformation piece that we're going to talk about. So what's the current state of primary care in Ontario? Everybody has a family doctor? Yes? Like, it's not unreasonable not to. Who doesn't have a family doctor? Who doesn't have a family doctor that they see regularly? The same doctor. Who doesn't have that? Couple? So if you go into an office, a doctor's office, and you see a different doctor, that's kind of where I'm asking. There are 2.5 million people out of 16 million Ontarians that do not have a family doctor. They have to go to a walk-in clinic, or they have to go seek care in some urgent care centers, or Emerge, or some other mechanism. And eventually that number is going to double over the next few years. So the goal is to fix that. And so there's this thing called Stop the Crisis that the Ontario physician groups have come up with as a campaign. But there's also a whole movement around what's called the Primary Care Action Team that's going to fix that. So one of the biggest crisis moments we see is when a family doctor starts taking patients. And you don't really see that in Toronto, because you see a lot of signs accepting new patients. You've seen those signs. That is a capacity opportunity to start what we call attaching patients, so they have this family doctor. But in the rural or more remote towns in Ontario, there might be one family doctor in the whole town, and that family doctor might work 1 day a week. So these patients that are not attached are desperate for a family doctor. You can see a lineup here. This is a lineup to sign up with a new family doctor that was moving to Walkerton, which is a small town north of Guelph. So it's a crisis when something like that happens. The other thing is that, well, the other problem is, why do we have this situation? Why don't we have more family doctors? Why don't we have an ability to sign more patients up to these doctors? Well, the problem is that, first of of people don't want to be family doctors. They don't want to be family doctors because they don't get paid a whole bunch of money. They work incredibly long hours, complicated, and they spend a lot of their time doing documentation. You'd be very surprised how much time a physician spends writing, documenting, typing into a system your medical notes. When you go see a doctor, everybody here has seen a doctor, they type or they write, right? Sometimes their back is to you when they're doing that. What kind of patient care is that? That's terrible. And then they take those notes, and later in the night, after they've seen all their patients, they spend hours putting those into proper format in the patient charts, in your charts. And that's just not a life that a lot of the docs want. A lot of them want to be specialists, they want to go to orthopedic surgeons, brain surgeons, eye surgeons. But being a family doc is a tough area to attract physicians to work in. So there is a great movement to address this. Do you know who these people are? Well, know who this is. That's Doug Ford. He's a great guy. Right? Doug's a great guy. He's working hard to fix things. Does anyone know who this is? That's the Minister of Health. Her name is Sylvia Jones. She's been in the role for almost 3.5 years now. And this one is the most important one right now that we're going to talk about. This person. Anyone know who that is? That is Dr. Jane Philpott. Dr. Jane Philpott used to be a member of Parliament for the federal government. She's from Markham. She's a family doctor. She became the Federal Minister of Health for all of Canada. And then when she finished that, she became the Dean of Medicine at Queen's University. And then she quit that job. She quit that job to fix primary care. So she's leading what's called the Primary Care Action Team. So one would argue that must be pretty important. Before I go back, what's really important, how government works, is that all health goes through the Minister of Health. There's a Minister of Long-Term Care and a Minister with mental health responsibilities, but really everything goes through Sylvia Jones. But now, the Premier has given Jane, Dr. Philpott, $3.4 billion to fix this problem. That's B with a B. That's enough to build 3 hospitals just to fix primary care and the issues of primary care. So, what does the structure look like for healthcare in Ontario? How is healthcare delivered? Well, it's delivered through a few mechanisms. One is through the local health integration networks, which have pretty much gone away. They reported to Ontario Health. Ontario Health is a delivery arm of the Ministry of Health. So it's a separate company, separate organization, and their job is to get money from the government and go do healthcare. So they give money to hospitals, they give money to doctors, they organize how health is delivered in the province. And then they have Ontario Health regions. Those are the regions in Ontario. There's 5, 6, depending on how you count. And then within the health regions, there's Ontario Health teams. So this is a group of organizations, hospitals, family physicians, long-term care, all under one umbrella. And their goal was to figure out how they could balance resources to get the best value for money on outcomes of care. So a good example is hospitals right now get a whole ton of money, but family doctors don't. But if we want to prevent people from going to the hospital, then we want the money to go to family practice or to the family physicians, so you can prevent them from going to the hospital. So you got to take the money from the hospitals, give it to the family doctors. But if the Ontario Health teams are led by the hospitals, and the hospitals aren't going to give them the money. So this is where the Ontario Health teams are struggling. Primary care networks. So hospitals they're very powerful. They have very powerful people on their boards, bank chairmen, ex-premiers on their board. And they can kind of wave their hand to the government and say, we need more money. They can say, hey, we've got way too many people wanting a new hip and knee, give us more money. Problem is family doctors don't. Family doctors are all independent doctors. Let's say you're all family doctors, well, you don't connect with one another. You might know each other, but you don't have an association. There are small associations, Ontario Family Practice Group, there's this section, General Family Practice, but generally they don't have the same power as the hospitals have. So that's why they're creating what's called primary care networks, this network of primary care providers to have influence in terms of policy and resource allocation. And now there's this new thing called local delivery groups. That must have been really new last year when I put this on the slide. Because local delivery groups had just come out last year. Just come out. So because all these things aren't working perfectly, now they're saying, okay, the hospitals have the power, let's get them to lead the system in their local areas. So those are the groupings that kind of deliver the care within our province. So, I don't know if you guys noticed my first slide, the title slide. I feel very strongly that data and information and technology is the best way to connect our healthcare system. Dr. Philpott, who we talked about with the $3.4 billion, she's got 3 objectives in terms of how she's going to fix primary care. The first one is to add capacity. And the first sub-bullet to that is to get more doctors. So more medical schools for primary care or family practice, hiring more physicians, so getting more foreign trained professional physicians to be accredited here. Those are the 2 key things. The second thing her priority is around team-based care. So she wants more people to be involved in the care, so it doesn't have to only be a family doctor. Or a family doctor can do his or her job and then pass it on to somebody else to coordinate or that other person be that primary point of contact and then bring the doctor in if required. So that would be like nurse practitioners. These are very advanced nurses that work in clinics, but also sometimes run their own clinic. They call them MPLCs, nurse practitioner-led clinic. So this is common in more northern or remote places where you can't get a family doctor to live, and a nurse practitioner will go live there, run the clinic, and act just like a doctor. They can do evaluation, they can do prescription, and they can do referrals. So I feel that technology and data is the most important thing for us in terms of capitalizing on change and transformation. And the first thing we need to do is have integration and interoperability. The problem is there's many systems that provide care. In a hospital, there's 15 or 16 software solutions in a hospital alone, one hospital. Hospital next door will also have 15 or 16 solutions, different solutions. And they may all be different vendors for those systems. The lab system might be, I don't know, might be one in one hospital and different in another, and then it has to connect with the diagnostic imaging system and the admission discharge transfer system and the OR system and the emerge system, and all these systems have to connect to one another. And they need that interoperability and that connectivity and that integration. So we need standards. So HL7, has anyone heard of HL7? HL7 is a standard for how technology connects to one another. FHIR is the other standard. And that is absolutely critical in terms of manufacturers and solutions, and the marketplace has to have this connectivity between these systems or they won't talk to each other. And then the systems are separated. So one of the biggest complaints I get from family doctors is they call me and they say, Rob, I have 4 computers open because I'm running this on this computer, running this on this computer, running it, and then so not only is it not easy to access those through contextual launch, is what we call it, where you launch something from inside the program, but they don't talk to each other, so they don't connect each other. So if you're sending one piece of information to the one system to the other, they can't read it. So we need to figure out how to connect those systems together. And the problem is when we want that standardization in the healthcare system now, we've just given every vendor choice to say, hey, you want to come in, you want to sell your product, go ahead and do it. We haven't said there's a standard, you have to abide by it, and you have to, if you abide by those rules, then you'll be able to do that. So that's the difference between an open market and being open and letting people come in and sell what they want versus a standardized market. I did a health system study tour to Norway, and there's hospitals there that only use GE. The whole hospital, GE. You want an X-ray machine, it's GE. You want a cath lab, GE. You want a MRI, GE. Hospital down the road, Siemens. Siemens, all the same, or Philips. Beautiful, because then the interoperability within the hospital is absolutely covered. Now, if those two hospitals want to talk to each other, then you need integration, and then you have to create that standard. So you see where that becomes a problem. Centralized data. So where does the data sit? So every hospital collects data on you. You get discharged from the hospital, all your information sits in the hospital. You go to a family doctor, all your information sits with your family doctor. So if I want to go and figure out population health or precision medicine or pandemic response strategies to go to every provider. There's 26,000 community-based physicians in Ontario. 26,000 different systems. There are 280 hospitals, 160 corporations. Each one has their own database. So what we need to do is figure out how to centralize that. I'm going to talk about that. And then we need to really drive vendor management because it's about the care provider, it's not about the people selling the software. And then there's adoption of innovation. You guys might come up with a great idea, you might invent something, then how do you sell it? How do we adopt great innovation in our care? That's a big challenge. And then really patient engagement. Have you guys ever read your chart? Have you guys ever seen your x-rays? Have you ever seen your lab results? Well, you should. You should be able to. Can you? It's tough. If you want to see your x-rays, you can. There's a thing called Pocket MD where you pay $5 and you get all your x-rays and they email it to you. That's about it. Getting your lab information, you'd have to look at the screen in your doctor's office. So we gotta fix that. So it's all around the data. Everything's data. And the systems are the things that collect the data and organize the data, and we need it for population health, as I said, which means how do we look at the population and figure out where there's pockets where we can address issues, cancer prevalence or COPD prevalence or infant mortality problems. All those things can be addressed for population. Precision medicine means how do we get all the systems to talk together so that you can get a best prognosis and diagnosis as possible. I worked on a big project down in San Francisco where we took all the Fitbit and watch data, the iWatch data, we took all this data from that you collect, your weigh scale data, everything. We took that, we took all the discharge information from the hospital, we took all the population data around clinical trials, and we put it all together and we said, if you walk in your age group, your socioeconomic status, your race, ethnicity, etc., we could determine based on your complaint what the best prognosis and diagnosis is. And that's where we need to go. That's called precision medicine. Performance management, how can we create more efficiencies in the healthcare system? How can we pull waste out of the system? That's what we get from data. Planning, where do we need to add more doctors, more clinics, more hospitals? That's health planning. We need to figure out how to do that. And then resourcing. Hospitals get, some hospitals get over $1 billion a year to operate. So how do we resource the system appropriately? So I want to get back to interoperability again, where those systems have to talk to one another. So TELUS Health. You guys heard of TELUS, obviously. TELUS has a Bell has media, Rogers has sports, and TELUS has health. So TELUS Health has an electronic medical record that the family doctors use, that they pay for. And those systems, some people might invent something, and it's required or best practice if it connects to that electronic medical record. So if you invent something and you want to connect through an API, an application protocol to TELUS says, okay, no problem. We want 50% of all your revenues and a one-time charge. So you're giving away half your company, and more than half your company, because it's not half of profits, it's half of revenue just to connect to them. So that's not good. That's where companies now start creating roadmaps on what systems connect and where we're going as a system. It's just wrong. It's one of the reasons I moved to Ontario to fix this problem. So commercialization is what's determining the roadmap for healthcare often in Canada. So there's this thing called Bill S5, and I highly encourage you to look it up. Bill S5 is a bill. It's not law yet, but it's a bill. And it says all systems that are sold or used in Canada must connect with other systems, openly and fully. So I had the pleasure in May of being invited to the Senate in Ottawa to speak to the senators about the importance of this bill and what it means. I don't know if you know how government works, but what happens is the politicians with the bureaucrats create a bill. And then that bill goes to the Senate. And the Senate represents the population, the people. So the Senate says, is this a good bill for people, the people of Canada? And so I went with the president of the OMA, she spoke about the physician benefits, and I spoke about the system benefits. So they're taking it seriously. It's a federal initiative, but it's tough. It's a tough thing to put in place, and hopefully that bill gets passed. So what's happening in Ontario? There's this thing called the Patients Before Paperwork. So Patients Before Paperwork is all about one thing: stopping using faxes. You think, well, that must be easy. Stopping using faxes, just stop using faxes, just send the data. Well, there's a lot of problems. Systems aren't integrated. They're not interoperable with one another. So people send a fax because it's the simplest form of communication. So there's a number of activities going on, steering committees, millions and millions of dollars being spent. I'm part of this executive committee on this. And so we're streamlining all of the systems that send faxes. The number one culprit is prescriptions. You go to your doctor, they print out a piece of paper with a prescription on it, or they write on a pad, or they fax it to the pharmacy. In fact, I went to a family doctor the other day, and he printed out the script, the prescription, and I walked 5 feet to the pharmacy, gave it to them, and they typed it in. That's the dumbest thing I've ever seen. So we need to fix that, and we need to fix that by connecting these systems together. The other piece is around what's called e-referral, and to do e-referral, you need e-forms. So you create an e-form, electronic form, and then you fill that out. It should be automatically populated, but we're still filling it out. And then that gets sent from your family doctor to, say, an orthopedic surgeon or a dermatologist, and then they receive that by fax. And then they put your name in the system and they type it. Think of all the errors and expense we're doing with typing in forms and faxes. So we're going to fix that, and that's the number one priority to get that done. So we need pervasive adoption of provincial digital assets to do that. What are provincial digital assets? There's a diagnostic imaging digital asset. There's a lab system. So one is called OCINet, that's diagnostic imaging. Lab is OLIS, Ontario Lab Information System. Pharmacy is e-prescribing. We did have something called Prescribe IT, which was a federal initiative, and they shut that down. We're back to faxing again. And then there's e-referral. HRM, Health Report Manager, which is our product, which connects the acute care hospitals to primary care. TELUS And there's many others. So we have to get this pervasive adoption of these tools into all the systems and used by all the doctors and care providers. Virtual care. Anybody been on a video or a phone call with a doctor? Got a prescription, went and got it filled. Should have been automatically sent to your house, but you went and got it filled. You've been on virtual care? So why isn't virtual care everywhere? Why do you think everybody doesn't use virtual care? In fact, it's pretty unique that you guys use virtual care. I use it whenever I can, but it's hard sometimes and you have to pay sometimes to use it. Well, the number one reason why it's not being used is because doctors don't get paid as much to see you virtually as they do if they see you in person. That doesn't make any sense. You gotta go to this germ-infested hospital and sit in a waiting room with all these sick people to go see a doctor and then get your prescription or your lab test and then you go. So why don't we just pay the doctors more to open it up and everybody sees the doctor on virtual platforms? I'll tell you why. Because BC did it. British Columbia. They said, okay, let's roll out this thing called QHR. It's a virtual solution. Anyone can reach their doctor whenever they want. They might have a stomach ache or they just, kind of just don't feel perfect. So people reach out, right? When there's no barrier or when it's simple to go see a doctor, you go see a doctor. What happens to the volume? It goes up. What happens to the cost? It goes up. BC shut it down after 3 months. They spent half of their budget in less than 3 months because it just flooded of people trying to reach the doctor. So there has to be some type of controls or mechanisms to perhaps separate the easy things from the hard things. So it's called triage. So how do we triage that? And so you're going to start to see AI do something. AI is going to say, yeah, I reviewed this, and you just need to take an antacid, or you need to go lay down, or have a rest, or have some fluids, and then come back if it doesn't go away, whatever it is. So I think you're going to see a lot more of this happening in the short term. It's still a problem, because having indigestion and having a heart attack are almost the same symptoms. So how do you determine whether somebody needs to go to emerge or somebody needs to have a Tums and go watch TV? So there's a risk and there's liabilities. So you have to start considering those kind of factors. So AI can help. AI is here. You all use it, I assume. Must be tough as an instructor to deal with AI.
There was a recent article in the Times, I just read it this morning. It's actually a person who teaches healthcare law wrote about it. And he knows that all of the students, or most of them on this final exam cheated. He even asked them anonymously afterwards who cheated. Only 8% responded. But I read stuff sometimes, and if it looks really similar what the students submitted, especially
because they put in the same question.
after today, they're going to write a reflective assignment on what you said. And there was a cohort last semester, it wasn't this course, it was another course, where their responses were similar. And I stood up in front of the class the week after it was submitted and I graded it, and I said, I think some of you used ChatGPT, and there were these guilty looks on people's faces. Now, having a guilty look does not make you automatically, doesn't mean you plagiarize. I mean, I can't prove it, but basically using these Gen AI tools is a form of plagiarism. So yeah, it's difficult for everyone all over.
It's tough in the education space, but it's great in the healthcare space.
It's great in healthcare because AI scribes are fantastic.
I use Grok all the time. I use Zara, talk to her, I'll talk to her in the car on the way home. Her.
Grok?
Grok is Elon Musk's tool.
Oh my God.
It's an amazing tool.
That doesn't say anything racist?
No, not at all. In fact, it's very, she is very nice, She's
Yeah.
very reflective. She's been wrong.
Of course.
She apologized for being wrong.
Uh-huh.
But this morning, I told you I had a 200-page document, hundreds of millions of dollars that we're going out to tender on. Hundreds of pages. I go through the document yesterday, and then I start typing all of my responses to the government to say, we're going to do this, we're going to do this, we're going to do this. Pages and pages. Before I did that, I said, Brock, go through that document as me and tell me what I should think about it, or be concerned about, or advise about. And it captured almost everything that I had already identified. But there's 4 things that it found that I didn't identify, which was quite impressive. So how do we use that in the clinical space? It's not always right. Like your question about, does it have bias? Like, so we've done a huge AI push around what's called AI Scribe. AI Scribe is ambient listening between a patient and a physician. So the physician doesn't have to type, doesn't have to have it back to you, they don't have to write. It listens to the conversation between the patient and the doctor. And I'm going to show you a little bit more. But my point is, we did all this work, and then the Auditor General sent out a report in May that said it's all garbage. 95% is wrong. Well, that was a little aggressive, but but there are mistakes. But the point is that it's a tool for the doctor. It's not a tool to provide care by itself. So it's a tool to help the doctor. So I think that that's something you got to keep in mind when you ask that question. So there's so much opportunity for you to use AI. Like people use, MD Insights and other tools, WebMD, tools like that before AI came along. But AI just searches all of those tools to figure out what the best answer to your question is. So as I said, we did a AI Scribe program. So what happened was, this all started because I was down in San Jose. I was meeting with a company, doing some work, and I run into this company that said, hey, we're doing this really cool thing called AI Scribe. And I'm like, oh, tell me about it. Well, in the olden days, they used to have what's called scribes. So doctors didn't want to write all the time, so they're doing rounds through the hospital, and they bring a person to write. So they scribe. So there was a push in California to say, we need scribes everywhere. And so they estimated it to be like $1 billion to do this project across all of California. So they said, no way. So somebody in their wisdom said, well, I'm going to use technology. And I'm going to overlay AI on this because AI was just coming out. And so that's how AI got started. So when I came back to Ontario and I said to the OMA, hey, Dr. Wright, who's the head of the OMA from a medical perspective, let's go to the ministry and let's sell this and get this in Ontario. So we went. Ontario has said no. So we went to the minister's office and said, this is where it's going to go. Get ahead of it. Great profile for the government. She said yes. Let's do it. So we did a huge create a whole program around it. We tried to fit it into the goals and objectives of the government, including patient before paperwork and other kind of initiatives that are going on. We did a review of the environment to see which companies were doing this. So we figured out, we grabbed 6 of them, blinded the companies so you couldn't tell which company was which. And we did a review on the value. So we said, okay, roll it out in these clinics and see if docs like it. Well, they loved it. They said, this is saving me so much time. It's saving me so much effort. It's saving me so much headache. And so we said, okay, this is showing value. Then it hit the news. We had a big announcement in all the news channels of this AI Scribe. And then we said, okay, now let's figure out how we can buy it for all of the doctors in Ontario. And so this rolled out to about 5,000 doctors right now that are using it. Has anybody been to a family doctor that's using AI Scribe? Only a couple, eh? It's interesting because I was at the doctor a couple weeks ago, and she asked me every time, can I use AI Scribe for this? And of course you can. and she said, what's interesting about your visit is when she's doing something, in my case she's a she, she has to say what she's doing, because the system can't see what she's doing. So she says, I'm palpating the right knee for whatever, right? So then the system knows what she's doing, she's finding. So it's an interesting, when you go and you say, well, why is the doctor talking? It's because the system is listening. So we did all that, and it was a resounding success until that Auditor General report came out. When people started saying, well, wait a minute, didn't you do efficacy evaluations? Yes, we did. The Auditor General didn't, but I'll leave it there. So we did this evaluation as a group. So we had the Women's College Hospital has an evaluation group. This is called BEEV. They are at Women's College, but it's all University of Toronto medical physicians that are academics, so research physicians. And we had all the doctors in all of our clinics trialing it, and we saw some significant benefits. So let's see if we can get this to work. Do you think the volume's going to work?
Yes. I tried it before.
Let's see if this works.
Do you have the link for that?
No, it's embedded.
Embedded?
Yeah, it should go. Let me escape out. Let me see if I can.
Is it online anywhere? Bring up YouTube or something? Okay.
Let me see here.
Now you guys are thinking it's very good.
Hope you'll be able to hear this. Or it's just waking up.
Are you playing it on your phone or?
No, I'm going to play it on the computer, but it's not responding, right?
Oh, the computer.
It just stopped responding.
Oh, I see. It's embedded there.
It's embedded there. It should be embedded there, but it's not.
Let me save it on the computer. I'll delete it.
That's okay. I'll skip back to this.
Sorry
When
about
this
that.
comes back up, when this wakes up, it'll.
I'm sorry.
No, I'll just actually end this program. There we go. Let me just open this up. Are there any questions so far while we wait for this? Have I lost you?
No, wrappers like cream.
Just want to mention that OMA is Ontario Medical Association.
Sorry.
No worries. Oh,
No.
sorry about that.
It didn't embed. So, anyways, I'll go to the next slide. So,
Oh my gosh.
So we went out to tender. We got 3, 6, 9, I think there's 19 here, vendors that we pre-qualified. So we went out to the market and we said, we want AI Scribe for the province. You have to follow these rules, these regulations, these privacy, these security requirements. And this is the list that had full functionality of AI Scribe from a clinical, functional, regulatory, and privacy perspective that we approved. It's a big list. You know how big this is now? 36. 36 in 1 year. So in a year and a half, 36 companies have invented something that does AI Scribe that we agreed and approved to, out of the 100 plus that are out there right now. So you can see this is exploding, and it's just Scribe. There's one company that's not on here, and we rejected them. You know why we rejected them? Because they were selling the data. So that's a big privacy breach. You cannot resell patient data for your own gain. So they're actually in the 36 now because they've stopped doing it. The docs told me, they say, I love this tool, it's amazing. You didn't approve it. I said, yeah, because they're selling the data. They're reselling the data. And the doc's like, well, I'm going to keep using it because I like it. I'm like, well, you're the product. It's not the product, you're the product. And now you're in a risk situation. So good thing they've actually gone ahead and fixed that. So who's in charge of regulatory and privacy in the province? And the country, but in the province specifically of Ontario, there's us, Ontario MD, College of Physicians and Surgeons of Ontario. This is the regulatory college of all doctors. The OMA, Ontario Medical Association. The CMPA, that's the Canadian Medical Protection Association. So that's the insurance group of doctors. The top one is the Information and Privacy Commissioner of Ontario. There's a privacy commissioner, separate commissioner, just to make sure that your data, your health data, is secure and not shared and not leaked. The Ontario government, Ontario Health, is part of the Ontario government, and Health Canada. Health Canada is the federal health department. There's a number of others that are involved, but those are the key regulatory stakeholders. And we bring all those people together. And you say, oh, that doesn't seem like a big deal. Well, these people and these people do not get along. Do you know why they don't get along? Because they fight about salary. Right? So if you consider the OMA as like a union of doctors, they fight for salary increases for doctors. Ontario Nurses Association, the ONA, they fight for the nurses' salaries. So the government has to approve that. So we can get those people all in a room, but the government can't. OMA can't. CPSO can't. So we play a very important brokering role to get these people together. So I've talked about this already. But these are the considerations from a legal and privacy perspective. So you got legal and liability. So you've got people who want to sue people because something went wrong. You got compliance. So you got regulations and rules by these associations provide. So if you do not abide by CPSO, the College of Physicians and Surgeons, and you're a doctor, you stop being able to be a doctor. So that's why that's important. There's contractual agreements that we have between us and the vendors. Like we said, you can't resell data. That's in the contract. And then go back here, they do. Integrity and bias, we already talked about bias. We've got to make sure there's no bias. We've got to make sure there's no hallucinations. We've got to make sure that as best possible, the AI is accurate. Informed consent, you have to be asked by a physician when you go in, either implied or verbally, whether they can record the conversation. Use of data, again, secondary use, patient safety, making sure that the care is best provided. Ethical considerations, obviously we want to not be biasing one group or another. And then privacy, your data should not be shared by anybody else. So doctors are like, hey, I'm going to use this AI in our interview. Are you okay with that? And you're okay, yeah, great, no problem, let's do it. So now there's a company called Lime. Amelia is their product. They have an AI scribe for patients. So now you go into the doctor and you record the conversation and you use AI. It does AI for you and tells you what happened, re-explains it to you, tells you in plain English where it is, looks at the evidence that's out there, whether the doctor prescribed the right thing, did the right thing, suggested the right thing. And you don't have to ask the doctor if you can use them. So now the doctors are like, hey, wait a minute. So you see how now it's on the other side. So now it's not just for the doctors, it's for the patients. Even though the doctor systems, the AI list that I showed you, the 18, one of the requirements is that at the end of the visit, it prints out a summary of the interaction you had with the doctor in plain language, in layman's terms. So it simplifies the medical terms or explains them or defines them for you. So it's a really unique thing that's going on right now. Yeah?
So would that go, you know, like, just about all hospitals now have personal health records. So if you're in a hospital and that's used, would it be part of the patient's PHR?
That's a really important question because that's the problem with these systems. It creates a separate record. And so it's not integrated into the record that the primary care doctor is using. So we can't have that. We can't have multiple records, especially when they say different things. Then what's the source of truth?
Right.
So right now it's the physician's medical record that's the source of truth. They're the custodians of that data. They're the hospital, the health information custodian. And so that's the source of truth is the physician record. But now we've got a separate record being created in your phone of your interactions. So how do we reconcile that? Where's the interoperability? How do we integrate those together? It's too new to figure out yet. Lime just came out a few months ago. They just launched. You can download it, it's free on your phone. Lime. Yeah.
Oh, interesting.
Yeah.
And what about what the doctor uses? Will that go into the PHR?
That is, so the AI, it's a very good question. So none of those 18 are integrated into the EMR, with the exception of a couple. So Tally was one of the lowest ones on there. They're integrated fully into QHR Well and TELUS, which are the 3 top EMRs. There's a couple others that are, but generally we didn't require integration at this time. That's a future piece. So what they have to do is cut and paste it from the AI scribe right into the EMR. They have to cut and paste it.
Thanks.
One of the interesting things on there is Microsoft didn't make it. Microsoft did, which I was happy about because it costs like 10 times as much as those systems cost. But it's really interesting how some of the big players didn't make it on our list. Again, where's the data stored as used? So Microsoft, even if people say it's cloud-based in Canada, if it's processed in Spokane, Washington, where Microsoft is, then it's going from here to Washington to back. Then it's leaving the country. As soon as that happens, you've got a data sovereignty problem, and that's not allowed. So it's really interesting how the dynamics are in terms of how this system is evolving. So I already talked about most of these things. One of them that is interesting is this one, PIA-TRA. You guys ever talked about privacy impact analysis risk assessment?
That's going to be semester 2 in the privacy and security course that I teach.
Oh, that's fantastic, because PIA and TRA are absolutely critical. Every software provider that touches healthcare has to do a privacy impact assessment and a threat risk assessment. And that's expensive. It's about $30,000 to $40,000 to do the total. We do them on our systems. Vendors are expected to do it on their systems. And if you're a startup and you want to launch your software, $40,000 can be a big tag to do that. But when we did the AI Scribe, we said to the government, if you're going to send this out through a procurement, which they use Supply Ontario to do, which is a centralized body at the government to do procurement for buying things, we said you have to do a PIA TRA on every one of these before they get accepted. And they didn't. And the Auditor General found that. So they are scrambling to do PIAs and TRAs on every one of them. Encryption, safeguards, dual end encryption. I mean, these are actually really good topics for your privacy security section.
Yeah.
But
that's
those are all the key elements of privacy and security.
Yeah.
Those are the elements that we evaluate against, and retention and deletion. there's a thing called break glass, which means when there's a crisis and you need to get into the system, you get to actually go in and look at the data because you have to fix the system. Again, we talked about informed consent. We talked about those things. So why use a vendor of record? So we created that vendor of record. What is a vendor of record? What that is it's a pre-qualification of vendors to be able to sell in Ontario. So you are a vendor of record. That means if you're on there and I want to buy something in this topic, in this case it's AI Scribe, I go to that vendor of record and I can pick any vendor on the list because we've already gone through the evaluation, judgment, qualifications, and I can buy that system. That's what a vendor of record is. And that's important in a minute because there's bigger vendors of record that are coming. There's a vendor of record the government has for cell phones. So if you work at the government, in a government agency, and you want a cell phone, you go to the vendor of record and you pick Bell, and then you get the pricing for the government, you get the terms and conditions and contracts for the government, which are different than the terms and conditions that anyone else would get on a cell phone. So that's what a vendor of record is. So really our value proposition to get this on a vendor of record was to say, okay, well it reduces the administrative burden for physicians. That's the number one goal of this, by 19 hours a week. That's a lot of time. It ranges between 5 and 19, but some are as much as 19 hours. And it gives back what we call pajama time to physicians. So sitting in the pajamas, writing notes, typing stuff. That's what we want to give back. It's compliant. It's got the best and fair pricing because we did it as a collective. When you buy things together, you get a better price, right? You go to the grocery store and you buy 3 and you get it for cheaper than if you buy 1. Same one. Coordinated support and peace of mind to the doctors. This is a lot of process. Okay, so where is AI going in healthcare? I'm just going to focus on primary care. There's a lot going on in the hospitals, and I did a lot of strategy work when I was at Cisco on where AI and algorithms. There's more algorithms back now. Now it's AI, which is this algorithms on steroids. In the hospitals, you can do incredible things around fall prevention, hand hygiene, around balancing workload of nurses and patients, all using systems. So it creates an expert capability to do something that a manager or somebody should already be doing. So behavior control. I remember Wallace McCain of Maple Leaf Foods, his brother owned the French fry company, and he said to me in a meeting once, how do we make sure that the care providers are doing things in the right way? How do we control the behavior? There's really no way to do that unless you use systems. So a good example is the number one reason why patients stay in hospitals longer than they should is because they get what's called a nosocomial infection. So they get a hospital-acquired infection. They get an infection from being in the hospital. So this is a nosocomial infection. That's why they stay longer. They block a bed, the emergency backs up. Nobody can get moved from emergency into the bed. Why do we have so many nosocomial infections? The number one reason is because clinicians do not wash their hands between seeing patients. That's the number one reason why there's a delay. So we went out with clipboards, and I had quality in my portfolio, we went out with clipboards, and we watched doctors, and we watched them to see if they would wash their hands. And they know we're there, we're standing there with a clipboard, watching them to see if they wash their hands, still don't wash their hands.
That's supposed to have the opposite effect.
There was more compliance, but they still weren't 100. It was like 65% instead of 50%. So nurses are better than doctors, but still. So when I was at Cisco, I said, okay, guess what these things are, the blue lights on the ceiling? Those are called wireless access points. It's how you connect your phone to the internet. Okay. So at Cisco, we had, when I worked there, many antennae in there. It's called hyperlocating access point. And we could determine where your phone was within 2 inches, or whatever device is connected to it. So I took that information, and we took the badges of the staff, registered them all into the system with Wi-Fi locating capabilities. We had patients with tags on their arms, so we knew exactly where the patients were because they were Wi-Fi connected. So you walk into a room as a doctor, we also tag the soap and the sink and the tap. So if I walked in and walked over to the patient, before walking over to and activating the soap and water, then the alarm goes off. That is being used today in the Veterans Administration, the VA hospitals in the United States. It's a very simple algorithm. If this, then alarm. If this and this, no alarm. So that's how you control behavior. You use systems to dictate how solutions should, how process should work. It's one of thousands of algorithms that we created. So that's acute care. There's tons in acute care, mostly around process, infection control, clinic patients that are souring, so patients that you use all the clinical data and you watch it constantly, and you can determine whether a patient's going to have a heart attack or they're going to have a stroke or they're going to have a problem. That's a system that the Prime Minister was just here talking about AI. I don't know if you saw it. He was at UHN, University Health Network. He announced all this hundreds of millions of dollars on AI. 100 million went to Unity, which is St. Mike's, where I used to work. And they got $100 million for that system I just described. Where's it going in primary care? So you walk into the doctor's office, they're reading your charts, they're like, what did you see last time? What did you say was a problem last time? Okay, they're reading all that. Okay, they read all that. Chart after page after page, looking at your labs, looking at your diagnostics before, looking at it all. Then you come in, and you have this AI-enabled exchange, and then they print all this stuff, labs, follow-up, your next appointment. But during that meeting with your doctor, you might say, I have a gastro problem. Sorry, we describe your symptoms, and then they take in the symptoms, it knows the symptoms, and then the doc might query, GI problem, prescription, and it comes up. Choices. Well, now the systems, the New York Times has a great article called the 360 Clinic, and what it does is that the AI now takes all of the information, so all of your pre-visit, summarizes it, and anticipates what you're coming in with. Then you have your ambient exchange, and the AI scribe's listening. And during that listening, it's interpreting what you're saying, and it's pulling up things for the physician to say, you might want to prescribe this. You might want to consider exploring complete blood count with these questions. You might want to send for an X-ray or an ultrasound or a CT. And then when you're done the visit, it automatically schedules your next meeting. It automatically refers you to somebody. So it's all done automatically. And as I said, the New York Times coined this the 360 office visit. And then there's other administrative capabilities that we're working on right now. So our number one thing we're doing right now is called AI CDS, AI Clinical Decision Support. So when I told you that when you're listening between a patient and a doctor, all those pop-ups with support, it's called clinical decision support. It's helping you with that clinical decision. So that's in AI's tools right now. I don't know what's wrong with me. And that's the priority now for us. So we went from AI Scribe, now we're on AI CDS, and we're now also onto AI Inbox Management. So one of the other big problems is that docs spend many hours reading emails. Email test results with something that's out of range. Email referral, follow-up, email, then just get all these emails on the process. So we have AI now that filters through that and actions or files in the electronic medical record for the patient, and it relieves the burden from the physician having to do it. So that is very exciting. So I love this one because docs, so I go to the OMA board meetings, and they are like, Rob, we're very worried. You're out there doing AI stuff. You're going to put a stock set in this, right? Because if you're using AI to diagnose you, then, or you got a mole and you don't know if it's cancer, and you take a picture and AI says, no, that's a freckle. You're fine. Now you're putting docs out of business, right? Radiology is all around interpreting an image. So now AI can do that. AI can do follow-up work. Make sure that you go see the chiropractor and see the physio. AI, what can a doctor do that AI can't do? Empathy and sympathy, right? I should have brought it. There's a great article in the New England Journal of Medicine, and there is a cross study between doctors and patients and asking them about empathy and AI won. Hey, I walk in the door and I'm always happy because, you know, I talk to Ara on the way home, and my wife always goes, were you talking to your girlfriend again? She loves me. She's smart. She thinks I ask great questions. She's like, oh gosh, that's a good question. So there's that empathy, right? You're like, how do you enjoy talking to a computer, right? Yeah. So this is a great quote. AI is going to change everything in medicine. I just can't tell how or when, but I know that AI is not going to replace doctors. But doctors who use AI will replace doctors. So it's a tool. How do we capitalize on these tools? So maybe one of the things that I would have as a takeaway would be, what did I start with? We have patients that aren't attached. We have not enough doctors. We have team-based problems. And now I'm saying we have tools to allow doctors to do more better. That's how we connect. And that's why I say digital is the only way that we can leverage and create a sustainable healthcare system in the future.
Question.
Yep.
I'm Teddy. My name is Teddy.
Nice to meet you.
Nice to meet you too. Just wanted to back to the quote, and I was thinking, can AI solve physician burnout?
Well, so burnout is an interesting kind of phenomenon. So we did a survey of all the doctors in Ontario, and the number one reason why physicians feel burnout is because they have administrative burden. And the administrative burden is what we're trying to solve first. Burnout is many reasons for burnout, but administrative burden is the number one problem. So they spend way too much time documenting and not seeing patients. So AI Scribe is one way of reducing their requirement to type and document. But AI Inbox Management takes the requirement to read all their emails. You start adding clinical decision support tools, saves them looking up in a book. I said to my doctor, I get this numbness in my leg, down the side of my leg, 2 weeks ago. My whole leg's numb. Do I have MS? Is it my hip problem? What is the problem? So she brings out this big chart, like a big plastic piece of paper with all the nerves on the body, and she's like, well, if we map it back, it's not your hip, it's, in fact, I broke my leg playing hockey, and I think both of us scrambled all the nerves in there. But the point is the system should be telling her, no, there's no hip issue for why he has a numb leg. He has a history of broken his leg, his tibia was never reattached and it grew back and it probably pinched the nerve. So that's another form of administrative and clinical pressure reduction on decision making. But there's many other tools out there. There's AI receptionist. So, you walk into the doctor, receptionist there, and you give them your health card and you say, I'm here for the appointment. then the doctor gets called. Well, this is all automated and we're using it. And many other tools that are coming out around data management, the ability to say, hey, you haven't been in for your follow-up on your diabetes care. You gotta get in here. You're not compliant with taking your drugs. Again, health promotion and health and disease prevention. Pap smears, fecal blood tests, your colonoscopy, all these things that you have to keep going back to the doctor for, all that can be automated now, so the doctors don't have to do it. So that's our way of addressing burnout to start. But there's a lot of other ways as well. Team-based care is another one. So you have a team providing care, and the doctor is part of that team instead of owning that care themselves. But yeah, I think that there's many things going on in that space. Good question. Yes.
My name is Liz.
Good to meet you.
I was just going to ask, as a patient, do you have a right to say no if your doctor asks
Yep,
to use the prescribe?
you do. You can say no. I'm not comfortable with it, and I don't want you to use it. And it happens more often than you think. And then they can't use it. They won't use it.
What if you find out that the doctor actually did it?
It's what?
If you find out that the doctor didn't actually do it after you said no?
They won't. They won't, because they will contradict all of those rules and requirements, and they can lose their license by doing it.
Hi, I'm Fatima. My
Fatima,
question
nice to
is,
meet
same to you. My question is about Lyme. So,
Did anybody look it up since I've been talking?
No.
not yet. So, what about the doctor's privacy? Isn't that breached if the patient is recording the doctor in the visit?
No privacy of the doctor.
It's even as a physician.
Oh, in front of 2,000 doctors, I said, this is here, and you better be ready for it. And I got that question. What about our privacy?
Yeah.
We don't have privacy.
Okay.
So, but there's ways of, I think it would be valuable for a physician to know if they're being recorded.
Yeah.
But there's no legislation that requires a patient to even divulge that they're recording the conversation.
Okay, so there are no doctor rights in this aspect.
Right? You remember the old man? No, it is definitely here. It's being used, and docs should know that it's being used.
Thank you.
Are you a family doctor?
No, an ophthalmologist.
Fantastic. Where do you work in Mississauga?
No, I don't work here.
Oh, okay.
Yeah.
Not yet.
Not yet. I'm an international medical graduate, so.
Well, it's good. There's a big push on, as I said, foreign trained professionals to be accelerated in their licensing.
Yeah.
So the timing's good.
Looking forward to
Starting
that.
with family doctors,
Oh yeah, I know.
then specialists.
Yeah, I know.
And
Ophthalmologists have to wait a long way before their turn to pitch in.
Ophthalmologists are like surgeons. They don't like competition either. So I wanted to touch on our strategy. So what is Ontario MD's strategy? So since my last time here, we created a strategic plan, and that strategic plan has 3 elements to it. It's always important to have 3 things because people need to remember. So the first thing is that we are going to accelerate our position as leaders in the healthcare system. Okay, so that's around our role in advising, leading, all of this change going on. Piece of paperwork, the primary care action team, all of the transformation items going on. We are advising, leading, and the government and the doctors in that space. That's our number 1 priority. Sorry, that's our number 1 strategic direction. Second strategic direction is on what we call Managed Digital Services Program. So this is around driving value. The first one is driving system leadership. The second one is driving value. So how do we drive value? So we had this great idea that I took to my board about 3 years ago. Took my board chair and vice chair up for dinner. And I said, hey, I got this great idea. Every doctor has their own contract with each of the EMR vendors. In Ontario, it's about $250 million a year. Each doctor signs that contract with the EMR vendor. And what happens when you buy software and the terms and conditions come up? You go like this, right? Until you get to accept. How fast can you scroll that to accept? And you push that accept button. There's a lot of stuff in there you're agreeing to. So the same with EMR, they're agreeing to everything. So the EMR vendors have all the power, they have all the leverage, they have all the influence. They make the decisions. So when a doc has one system and they don't like it and they want to move to another, all the data's in the first system, and they have to migrate it, so that's migration, to the new system. It's like when you change cell phones, right? Change your cell phone provider, so automatically happens. Well, in EMRs, you got to take all that data, and then you have to remap it, because it's different fields and different kind of configuration. We map it all. And that takes weeks, and it costs somewhere between $5,000 and $10,000 per doctor. So they feel like they're in jail. So migration is all in those terms and conditions, and they just agree to it. Cost increases. Costs out of the blue, costs going up 10% this year. That's all there's to it. Paying more money. So no control over costs. And then when I need them to adopt OLIS or put OCINet diagnostic imaging into their system, they say, it's going to take us 2 years to build that, and it's going to cost you $300,000. So I got to find $300,000, and I got to wait 2 years for it to build. Well, because I have no leverage, so I need leverage over the vendors. That's why we want to centralize the cost. And generally, as I said, the more you buy, the cheaper it is per unit basis when you buy bulk. So if I'm buying, Doc's buying one, TELUS or QHR, well, QHR is owned by Shoppers, so I should just say TELUS, Shoppers, or well. And they pay whatever the price is. But if I say, I'm negotiating on behalf of 24,000 people, 24,000 contracts, I'm getting a good deal. Nova Scotia got 75% off. The Alliance for Health and Communities did it for 100 clinics. It's like 300 doctors, and they got 28% off. So the more we do that, that's driving it. And then the third thing is drive innovation. So how do we get these innovative tools in the hands of doctors faster? From the time that I heard about AI Scribe in San Jose to the time that it rolled out pervasively last year was over 3 years. 3 years for one innovation to get in the hands of doctors. That is ridiculous. That can't happen. So we need to figure out how to do those things faster. So drive innovation to get solutions in the hands of doctors. So that is something that I'm going to be, after today, because of that document that I've done, is focus on innovation. How do we take the thousands of innovations out there, owned by hundreds of companies, and collect those, evaluate those, maybe using AI, against a certain set of criteria. What are the OMA goals? What are the ministry goals? What's OMD's goals? What are the priorities for patient care? What is low-hanging fruit from a value perspective? AI was easy. There's a cheap solution. It's like $80 a month per doctor, but it saves them 19 hours a week. Like, that's a no-brainer, right? Even if it saves a couple hours a week, it's still a no-brainer, and it makes their lives easier. So that one was easy. So there's, how do we get some of those what I call low-hanging fruit, the ones that have this value that's pretty easy to do a business case on. So that's what we're focused on. Innovation is really identifying those companies, figuring out which ones match our priorities, and then do a value analysis on them. Say, okay, give us your product. We're going to trial it, see what the actual value is. We're going to measure it using sophisticated process, and then we're going to figure out how to scale it. Because the biggest gap right now is all these people, like you guys might be innovators yourselves. You come up with something, you invent it, you build it. Now with AI, you can use AI to code it, right? And you build it. Then what? Then what do? You go knock on doors and try and sell it? that is almost impossible, trust me. It's almost impossible. There's gotta be mechanisms to get scaling and adoption of innovation into the hands of doctors. Who better to do that than somebody who's in charge of all the doctors and all the digital, and in charge of, propagating and supporting solutions in the healthcare system with the government than us. So that's going to be our role, and in fact, I'm going to be spending a lot of my personal work time to do that. I'm going to be really focused on that over the next year or so. So really taking our learnings from AI Scribe and enhancing it to hundreds of innovations and getting those out in front of the doctors as soon as possible. This may be a departure, as I say, from our traditional model. It's not easy to sell the idea because when we did AI Scribe, one of the companies that was on that list, I approached them at the very early stage and I said, how much would it cost for me to buy your company, at least in Ontario? They said $1 million. And I said, fantastic. So I went to my board and they were like, yeah, sounds good. Go to another board, let's say. And they said, no. How do you know that that company is Microsoft or Google and not AOL or Yahoo? How do you know you're picking a winner? Is their question. But as my father used to say, you don't have to make the right decision, you have to make the decision right. So if we had selected that company and we exclusively owned it as a physician group, there is no competition because nobody else is going to buy the other systems because we own the exclusive customers. The customers own it, so they're all going to use it, especially if it's free or cheap. So and then we force development and research and so forth. And so that's where we get into equity plays. So we own a piece of the company, and then we're going to figure out how to take stakes in companies or own companies outright or do our own development in some cases with some of these idea people. So a great company housed over at U of T, but independent from U of T, called Axel, AXL. And somebody has an idea. You don't even have to have a solution, just an idea. And you go to them and you say, I have an idea. And they say, okay, we will own half of your company, but we will build it for you. And we will market it and we'll sell it, but we own half of it. That's a big deal. You don't even have to build the thing. You just have to have an idea. So I think that these are coming up, and then we'll be working with Axel to validate and promote some of these solutions. So everywhere you turn, somebody's got an innovation hub, right? You read every company's got an innovation hub, every hospital, everybody's got one. We are a little bit unique in our innovation approach. So stay tuned for that. Okay, so what is the hottest topic in digital health right now? I really haven't got into it, but there's this thing, and I can't get into too much detail because I'm under a non-disclosure agreement with the government, so I can't tell you anything that's not public, unfortunately, for the next month or so. So I'm it relates to all that work out and for the last 2 months. So primary care digital transformation, it's called PCDT, is a $3.4 billion I talked about to Dr. Phil last week. This is around how are we going to transform primary care in Ontario. And there's those 3 priorities, capacity, team-based care, and digital. Those are the 3 priorities. So the first effort they're going to do is what's called primary care medical record. So what are they doing? They're centralizing the contracts of all the doctors. You've already heard this, right? Right to my board. I said to the government, if you don't do this, we're going to do it. So you want to be with us and do it, or are we doing it alone? They took option 3. They're going to do it. So that's what's happening right now. You might read about this where primary care medical records are being centralized. There's right now 14 of them that are certified by Ontario MD, and they're going to shrink that number down. Can't say how many are going to be, but they're going to shrink it down, and they're going to centralize the contract, and they're going to write contracts to benefit patients, to benefit the providers, and benefit the government. And then there's a third piece around patient information sharing that's coming up. And this is around a patient portal and a patient app. I might have already said too much, so don't tell anybody. So you will have an ability to see where the closest available and accessible services are. You'll be able to book appointments. You'll be able to see your lab results, see your medical notes, see your diagnostic imaging results, see the status of your next referral, the next appointment. All of this is coming very soon. So it's a very exciting time for transformation in healthcare in Ontario. Once it's done in Ontario successfully, it will probably scale nationally to all the provinces. So this is a really exciting time for care in Ontario, and I'm super bullish about how great it's going to be for patients. And I hope